I'm Dr. Jam Katari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Hi, Sally.
Hi, Jam. How are you getting on?
Very good. Another day, another podcast. And today we're talking about a really interesting and important topic.
Well, today's quite a meaty topic area, I think. It's Smouldering Myeloma, which I always think is such a charming title, isn't it? But there we are. That's how we refer to this type of myeloma. So we're going to explore the nitty-gritty of what it is to be a smoulderer and what that might mean for the people who have this condition.
We did touch on this a little bit in our second podcast, which was What is Myeloma? So, Sally, if we just take it from there, really, and pick up the discussion from there, what is smouldering myeloma?
So smouldering myeloma is defined basically according to your bone marrow. So to have the diagnosis of myeloma, remember we spoke about the fact that you need a certain number of abnormal cells to live within your bone marrow when we look at it. So just to remind our listeners, the threshold for being labelled or diagnosed with myeloma is 1 in 10 cells or 10% cells that need to be these abnormal plasma cells. And anything above that is labelled as myeloma. But as we discussed, not everyone with myeloma needs treatment. And so for those patients who've been thoroughly investigated, they've had scans done, they've had their bone marrow, but there doesn't seem to be any issue with their myeloma, it's not causing those crab features, then you can label them as a smouldering myeloma and observe them thereafter. But there is one caveat to that, Jam, isn't there? Or a few caveats out to that, which we spoke about, I think, in our previous podcast, the slim crab criteria, which is where you don't have florid problems, you don't have kidney failure, you don't have bone problems, but you might have a few other markers which sort of push you over the edge towards treatment. So should we remind everybody about that?
In some situations, it's really very clear you're going to need to start treatment for myeloma because you have symptoms or you have organs that are just not functioning properly. So that's the CRAB that we talked about. So the C is for high calcium levels, which often happen when you have bony related problems. So that's the B of CRAB. Myeloma can stop your kidneys from working properly. So that's the R. Now, that doesn't necessarily have symptoms, but your kidneys not working properly is a big risk and they can stop working altogether. The A of the CRAB is anemia. So these myeloma cells, they like to live and multiply in the bone marrow, and that pushes out the normal working of the bone marrow. So that factory that makes all our blood cells, including our red blood cells, and they can't be made properly. So people get anemic and all the symptoms associated with that. So if you have any of the CRAB symptoms or organ problems, you need to start treatment for myeloma, and that's very clear. So the SLIM is criteria that were added about 11 years ago now for actually starting treatment, even though people don't have symptoms. And that's because these people may be just on the borderline of developing bone problems or developing kidney problems or developing other issues relating to anemia and the symptoms that go along with that. When they looked at this, they felt there was such a high risk. They were thinking maybe 80% of people with these specific criteria might progress within 2 years, that the safest thing to do would be to start treatment at that point. So should we just briefly explain what the SLIM is, Sally?
So that relates to some criteria which define this higher risk group of people. You could say that they would have once been labelled as smouldering myeloma and now they've either got high risk myeloma or this slim crab. And it relates to how many abnormal cells you've got in your bone marrow, so over 60%, and you're labelled as having slim crab positive criteria. It also relates to your light chain. So if you recall, there are 2 types of light chains that we all make. And in myeloma, some people, well, most people with myeloma actually make more of one than the other. So you divide the lowest number into the highest number. And if that ratio is greater than 100, that's one of your slim crab criteria. And the other is on your scans. If you've got more than one abnormal lesion of a certain size on your MRI scan, that meets the criteria for slim crab. So it's looking at blood tests, it's looking at the bone marrow, and it's looking at your imaging to see if you meet any of these criteria. And even if you only meet one of them, then you get a tick in that slim crab box, and that then pushes you over the edge into sort of being a high-risk smoulderer or a slim crab positive myeloma, and therefore treatment is recommended.
A whole podcast we could do on slim, which you've just very nicely described, because after 11 years, I think it has become apparent that actually not everyone does progress as quickly as people initially thought. But I think a key point to make in the context of this podcast is that people who have these so-called slim criteria relating to a lesion that's seen on the MRI, more than 60% myeloma cells in the bone marrow, or the ratio of the light chains that you mentioned, they have no symptoms. This is a completely asymptomatic phase, but the concern was that these people were just about to get symptoms, so you should protect organs and start treatment. Okay, and I think that's a good point to start talking about smouldering myeloma, because patients with smouldering myeloma have no symptoms attributable to myeloma.
That's true. It's almost like it's a chance finding that they've got this abnormal protein, and that then triggers all the investigations. And I think, as we may have mentioned before, maybe it's reassuring to come to clinic and say, well, you've got this condition, but, it's not causing you any problems at the moment. But I think it's really important to also for us to appreciate, particularly as clinicians, that can come with its own burden. Well, as we discussed previously, you're telling me I've got a type of blood cancer, but you're not going to do anything about it. And I think that can be very problematic, particularly for people living with a smouldering myeloma. Not everybody, but lots of people do. It can be very difficult to get your head around the logic of that weighting approach. And so what we essentially have done, or what the sort of global community have done with the slim crab criteria, is trying to sort of figure out more about that population of people. Which ones are the very highest risk, which are now slim crab. And then you can also look at the remaining smouldering myeloma patients and then try and figure out which ones of those are high risk as well. And that leads us to something that we in the UK refer to our 20-20-20 criteria, which I think internationally is more of a 22-20 criteria, isn't it, Jam? And can I pass that one back to you to talk about?
To have the diagnosis of smouldering myeloma, you have between 10% and technically 59% plasma cells in your bone marrow, and you have no organ damage attributable to myeloma, and you don't fit any of the slim criteria. So for whatever reason, a protein was picked up in the blood, you came to see a hematologist, you had the bone marrow, you had the tests, and those tests ensured that you didn't have kidney damage, your blood count was okay, you weren't anemic, and you had scans to confirm that you didn't have bone disease attributable to myeloma. And then you're in front of one of myself or Sally, and we say, yeah, absolutely, I'm sorry, but you do have this condition called multiple myeloma, but it's not affecting your body, and we don't treat it. Before I get to the risk, what we call the risk stratification of, well, what happens to these people, Sally, how many times have you sat in clinic and told someone that, and they just look at you blankly, right? So cancer, tick, you're not going to treat me. Smouldering myeloma, the whole area can be very confusing.
Oh, hugely, hugely, hugely. I think lots of questions arise from those consultations because it's a complex area, but also it's a lot to take in, isn't it? You've just told someone that they've got cancer, and then you're giving them this weird label of smouldering, which I always think sounds quite peculiar. And then you're trying to talk them through the fact, well, you've got cancer, but it's good news, we don't need to do anything about it. And I think sometimes that can be pretty hard to hear.
Yeah, and when I say we don't treat it, this field is evolving very rapidly. And there will be a whole podcast on when potentially smouldering myeloma could or should be treated, what parts of the world sometimes do they offer treatment, and clinical trials associated with it. But for where myself and Sally work here in the UK, the standard is to not treat, but to monitor. And Sally, if we can just sort of maybe have a little bit of a history lesson, why don't we treat it? And are there any other cancers that when people are diagnosed aren't treated? Because this in itself is an important topic, and a lot of people come to us and thankfully they haven't had to interact too much with health services. So the whole concept of cancer diagnosis and no treatment is difficult to understand.
Well, let's take that one by one. So first of all, let's think about why we don't treat it. I said earlier that we're trying to sort of figure out how each individual person with myeloma behaves, because as we've previously discussed and we're saying now, everyone with myeloma behaves differently. What we know about people with smouldering myeloma in this pre-treatment phase is that in the first 5 years, on average, if you take everyone together, the chance of needing treatment is roughly 1 in 10. And then for years 5 to 10, after you've been told you've got smouldering myeloma, it falls to 3% of people. So that's a very small proportion of people may actually need treatment. And then after that, it's even lower. It's a remarkable 1 in 100 people who were diagnosed with smouldering myeloma 10 years ago will need treatment every year going forward. And so what that tells us is essentially the risk almost diminishes with time, or rather the people who have got more unstable disease reveal themselves. It becomes apparent that they need treatment, and everyone else you can observe and observe closely, so that if they develop any problems, you investigate them very promptly. You're not just sort of asking them to go back to their GP necessarily and carry on as you are. You're keeping an eye on them, but hopefully you're then figuring out who's going to behave in which way. And therefore, I think it is very hard to make an argument necessarily for treating all of those people, because you run the risk of potentially over-treating people, basically turning our patients into proper patients on treatment where they may not need it. They may have been otherwise very well indeed. So it does become a very complex and nuanced discussion. And yes, Jam, there are many conditions, particularly in haematology actually, where we don't treat people. Chronic lymphocytic leukemia is a good example of that. And I know that you look after this cohort of patients as well. And you can often monitor this patient population for many years, if not more. So that's the first one. I'm trying to think laterally about other cancers, and I'm not so good at other types of solid cancers. Maybe some skin cancers you don't need to treat?
Our forte is haematology. Historically, there's a type of lymphoma called follicular lymphoma that often hasn't been treated until it became symptomatic. But a key thing is that, of course, historically, treatments for myeloma have not been very good, and we haven't been able to offer long-term remissions or cure, which we will keep bringing up this word as the podcasts carry on. So when you can't potentially cure a condition or change the natural history by treating it, or improve quality of life by treating it because it's an asymptomatic condition, the historical context is, well, why would you treat it if you're in a position to monitor carefully and then treat at the point you need to? And this is one of the key points still in smouldering myeloma. As you say, Sally, someone may get diagnosed and after a number of years still not have required treatment. And then if people are diagnosed when they're older, they may run into other health problems that lead to their demise when they're in their 80s if they're diagnosed at 75. So I think they're important historical context just to sort of give our listeners, if you're there with a cancer that doesn't have symptoms, can you improve their physical quality of life by treating? Well, no, because they don't have symptoms attributable to the cancer. Is there any old evidence or old data from trials to say that you can change the natural history by treating earlier? Now, this is an intense area of investigation, but there is nothing proven in this area. And then, of course, well, is it easier to treat and cure by treating earlier? And we don't have that evidence either. So that's why historically, when we have diagnosed smouldering myeloma, we haven't treated and we have monitored. And that's still the standard of care approach in the UK and lots of Europe.
That's a great summary. It's all about managing risk. And I also think smouldering myeloma is a real, it's very much a case of having a conversation with the person in front of you to figure out what their preferred risk approach is. Some people may say, well, actually, if you think I'm high-ish risk, please, can you consider treatment? And I think they'd have to, well, at the moment, no treatments are licensed, but it may be that there might be studies in the future that we can consider them for, as other people would say, actually, I'm going to step away from this till I really need it. And you can see the argument from both sides. It's simply not black and white, and makes for really meaningful conversations about what's important. And then there's one last thing I guess it is important to say, and we've spoken about this and we'll continue to explore this on this podcast, is treatments are evolving at pace. And so offering a treatment now when that person may not need treatment for another I don't know, 5 years, 10 years. In 5 or 10 years' time, who knows what that new standard of care might be? Who knows what drugs might be available that might offer a better outcome with fewer side effects, for example. So I think there's an argument for sort of waiting until you need it from that perspective as well. And that's how I think I would discuss it with the people I look after.
Everyone is seeing more smouldering myeloma, and that's partly because we're doing more bone marrows, because you get the information in terms of how many abnormal plasma cells are by doing the bone marrow. So many more people get put in the criteria of smouldering myeloma. And as you say, you do the workup, as we say, with the scans and the bone marrow and the bloods. Then you have someone with a confirmed diagnosis, and on the assumption that they maybe don't go into a clinical trial of a treatment for smouldering myeloma. If the approach is, well, we're going to watch you and watch you carefully, then we get into the key point, Sally, as well. What's our sense of the patient in front of us? Is this going to be one of the patients that progresses in the first 5 years? As you said, we may expect maybe up to half of patients to progress and need treatment, or is it a lower risk? And this sort of circles back to what we call the risk stratification, where we get information from their myeloma and give our patients a sense of what the next few years may look like for them. So Sally, I think I've put this back on you now. Can you tell us about what the most standard one I think that people use in clinic? And I think what I'd say is that if you have seen a hematologist and you have a diagnosis of smouldering myeloma, I do think this is something that should have been discussed with you.
I think that's fair to say. So this is the criteria that what I'm going to refer to now as a 20-20-20 criteria, which is whereby you can say essentially assign risk according to meeting certain parameters on your diagnostic test. So one is, have you got more than 20% plasma cells in your bone marrow? So more than 1 in 5 cells are abnormal. The other is your paraprotein greater than 20 grams per litre? Now, that's the one which can be referred as 2 internationally because the decimal place changes, but you're referring to the same markers. And the other is looking at this light chain ratio, which I spoke about earlier, and seeing if that's greater than 20. Essentially, you can tick boxes for having each of those things. And the more boxes you tick, the higher the chance of progressing. And therefore, the clinician perhaps, and should perhaps discuss it with the patient in front of them, how closely we might need to monitor that person, because we might think if they've got tick all 3 boxes, actually they've got high risk smouldering myeloma, and therefore we need to monitor them more closely because things could change for them. I'm emphasising could change for them in the months and years ahead.
So we can do a what we call a risk score, and you can with those 3 criteria, Sally, you can split people up into 3 groups: low, intermediate and high risk. So for example, if you are low risk, your chance of progressing at 2 years is 10%. So if you just take a patient who is low risk, I think you need to make a pretty good argument why you would treat someone. And to be fair, I don't think anyone is proposing that people with low risk smouldering myeloma are treated, but it's a great comfort to the patient to know that realistically, I'm not going to have a problem potentially for a number of years here. But as you say, if you are in a high risk group, that risk level is significantly higher. And Sally, there's a couple of extra bits of information that you can add on top of that might give us more information about how quickly or slowly someone may progress.
Yeah, there certainly is. I think you're referring to additional information we might get from the bone marrow tests, something called your cytogenetics or FISH, which are terms which are used interchangeably. Now, this definitely warrants its own podcast in terms of the complexity of this science, essentially. But to simplify it, what FISH or cytogenetics essentially tells us is, are there genetic changes within your myeloma cell, not within your whole body, but within your myeloma cell, where the DNA is either modelled up, or there's bits missing, or there's bits added on, that may mean that your myeloma behaves in a particular way. So there are some changes that we can identify on examining the bone marrow using specialist tests in the lab, which suggests that the myeloma might just tick over relatively slowly, whereas there are other changes which might suggest things could change more promptly. And I think if you have those genetic changes within your myeloma cell, then that might also make you as a clinician, a bit more mindful to keep a closer eye on this patient. But I think it's really complex area, isn't it, Jam? I think we've got a special guest lined up actually to explore that with us in the future, haven't we?
Absolutely. These tests are increasingly done now on all people who are diagnosed with newly diagnosed myeloma, which I think is absolutely excellent, because as a general rule, the more information, the better. And you can identify subgroups where, we think that maybe up to 70% of people may progress at 2 years, and other slightly lower risk groups where 50%. So, our job in the clinic is, I think, to really understand what the risk of progression is and think about how we monitor and how closely and how often we monitor people on the basis of that. Because if we're not going to treat, our aim is to not treat too early and absolutely not treat too late. I think the worst thing that can happen in this sort of situation is that you miss what we call progression events. So something happens that you can't reverse. Now, a lot of the time, the kidney function, you can improve that. Even if the kidneys start to stop working, they can often rapidly improve. And that is a function of how good treatments are now. Now, something that is not reversible and then can cause long-term side effects are if people develop fractures secondary to myeloma. And then I think, Sally, this leads in really to sort of the monitoring question, is that we've made the diagnosis of smouldering myeloma. We've worked out what we think the risk is. How do we monitor and how do we counsel our patients? Because there's sort of simple things to monitor, like blood tests, things that are more difficult, like symptoms. And so many people, when they get diagnosed with smouldering myeloma, every twinge, you're thinking, is that myeloma? And how do we counsel people about that, and what should we do? And I suppose linking into that is, well, how often should people get scans and clinic appointments? Can you take us through that?
Thanks, Jam. What a treat. So there are some guidelines out there to guide us all through, because this is a complex area. But in a nutshell, what's recommended is that people are scanned on an annual basis for the first 5 years. And that's whole body scanning. And that's partly because, as I mentioned previously, the risk of progressing for all comers is greatest in the first 5 years. Now, I think, again, that's a conversation to have with your team, because depending on which scans are available, that could be quite a lot of radiation with PET scans. Now, obviously, that's recommended because the benefit outweighs a risk, but nonetheless worth considering that. And then other ways in which you monitor is, as you said, really, it's symptom guided and blood test guided, which can be difficult because we all get aches and pains, particularly as we get older. And so I often say anything which sticks
You see me
around,
nodding about aches and pains as you get older. I'm just there going, yeah, absolutely.
Totally. And you can so understand why people, are concerned and quite rightly so. But anything that sticks around and is actually, particularly myeloma bone pain, is really quite unpleasant when it occurs. It sticks around. You can't put your finger on it. You don't know why it's turned up. And it's just worrying you. Get in touch with your team to get on top of it. And similarly, I think with the blood test, actually, it was a question I was going to ask you, Jan, to put you on the spot a little bit, is your blood test will fluctuate a bit. But I was going to pose a question to you that, let's assume I'm a patient coming to clinic and my paraprotein was 17 when I was diagnosed and now it's 21. Does that mean that I need treatment? If my light chain ratio has gone from, again, 17 to 25, does that mean I need treatment? How do you figure that one out?
Bloods can fluctuate for a number of reasons, and what's really important is to establish a trend of how things are moving. And there has been data published in the last few years describing what's called an evolving pattern, where these numbers are increasing often by 20 or 25%, maybe each time that they're measured. And it's almost like, to use a sort of mathematical analogy, you're on the kind of the steep part of the curve, in that it's been picked up just around the time where it's starting to become symptomatic. But a one-off reading compared to what we call the baseline, or say the first time we've measured it, doesn't tell us that much. And I think what's important is to know where you started and see where it's going. And I think if you're concerned that the numbers are going up, then you may wish to check them again after a shorter period of time, rather than leaving it the recommended period of time. And I guess that's a good sort of thing to bring in at this point, Sally. It's that, well, how often should we do blood tests? Now, as you mentioned, scans, once a year is the recommendation. I think for blood tests initially, the recommendation is around sort of every 3 months. But I think this is nuanced. I think people with low risk smouldering myeloma, I think perhaps, twice a year is probably fine. And I think for other people where you're a bit concerned or they maybe have more risk factors, you may wish to do it a bit more often.
I very much agree. And I think, again, what's important to share about this field is it's changing very quickly. Not only is our understanding of this condition changing so quickly, but also the intervention. So this story will change. And I suspect, Jan, when we're recording our 200th podcast in a few years' time, we will have to update this one because things will have moved on a little bit. And it makes it, an interesting area to observe. And we're part of that evolution, really, I guess, as we move forward. So, lots to learn and understand, that the monitoring is crucial and also that engagement with every person living with smouldering myeloma so that if they're worried, they can get in touch with us to hopefully reassure them that things are as we hope they are.
I think a key point is, we talked about these numbers, 10% in your bone marrow to 59%. These are arbitrary numbers and they don't tell you anything about the biology of the underlying condition. Now, you mentioned genetics, Sally. That potentially does tell you something about the biology. And really the key thing is that sometimes we will have someone in front of us and that is a person that was unfortunately always destined to get myeloma that needed treatment. And we just picked them up a bit early, and the point at which their organs were going to get affected was preordained, and it's going to happen in 18 months. And there's other people that we picked up that have a very stable underlying group of plasma cells that fit the criteria for smouldering myeloma as they have been defined by the international community, but it's going to stay and stick there in the background and not cause any problems for many years. Unpicking the biology is something that we are really learning much more about every year. So hopefully in 5 years' time, Sally, what do you think? Do you think we'll be able to give people a much better sense actually of what they have? It's like, I think you have something that's going to remain asymptomatic for a decade versus I can see now that you're going to have a problem in a year. We can't wait. We shouldn't wait. We should start treating. What do you think?
God, I don't know. I honestly don't know. I think let's be optimistic. Let's go back to our first podcast and talk about that cure thing. Until we are closer to a cure, so you can say going in early is going to have an impact on getting rid of your myeloma for good. Those conversations are going to continue to be incredibly complex because it's all about figuring out the risk and the upside and the downside of the treatment and the upside and the downside of waiting. And let's not forget, actually, when you start treatment, you're then kind of tied to the hospital for turning up, seeing your doctor every 4 weeks, having blood tests done, having this, that and the other. It's a very different life to one without treatment. And so you've got to be pretty engaged to embark upon that and actually clear about the benefits. So so much is going to move forward. I don't know which way it's going to go. I suspect we might be treating more people in the future. But I agree, there's some people who you and I monitor day to day now who perhaps met the criteria, but we're still not treating them because we've been looking after them for years and nothing's budged.
A key point to make. So there'll be people who have slim, of the slim crab, that count as myeloma that need treatment, and they may not have progressed for a number of years potentially because inherently they have biologically quite stable myeloma. And this is something that has intense arguments and debate at nearly every myeloma meeting. And, our job as hematologists is to keep abreast of it and try and give the best information we have to our patients at that point in time. Sally, I've got maybe a slightly more difficult one for you in that.
What a treat.
What a treat. I was saving this one. There is sometimes not insignificant psychological distress among some people. It's like, I just would feel better if you treated me. I understand the reasons that you're not, but just knowing that this is here and it is going to progress, even if it's slowly, can you just treat me now? And then I know psychologically I'll be better. So the impact is a psychological one, and treating improves the psychological aspect. What do you think? I mean, it'd have to be driven by some evidence that we could improve psychological well-being, or what do you think?
Yeah, I mean, I think so. Thanks for that, Jam. What a delight. I think we would have to prove that what we were offering was actually going to take away that psychological discomfort. I'm not entirely sure that we could do that, or that I could do that, in all honesty, because I couldn't then say to that person, based on today's evidence, that this is certainly going to change your outcome in terms of your quality of life, or how long the condition remains under control for, or indeed how long you might live for, or indeed that you actually need this treatment. And so I think if you put all that into the balance, I think that's where the onus really comes back to us as doctors to feel like we're doing the right thing. And that definitely is listening to your patients. But at the moment, I mean, we can't prescribe anything anyway. It's not licensed in the UK. But if it was to be licensed, I'd have to consider that very carefully. And I think if I fundamentally felt that actually, I don't know how to say this really, that actually I still would struggle with that prescription and consenting that person, I guess I'd have to refer them to a second opinion somewhere else to talk it through with somebody else, because you've got to do what you feel is right. Do you have an answer to that one, Jam?
I think it's very difficult, and I think the reason I brought it up because I think there is some evidence from some trials in follicular lymphoma, which is a condition also treated by blood doctors, that treating asymptomatic follicular lymphoma with, relatively straightforward treatment, has been shown to alleviate some aspects of quality of life relating to psychological distress. But there is much more data in that field for lymphoma, and it doesn't exist in myeloma. I think there's only very, very small studies, but it's the discussions that we have with patients with Smouldering myeloma, I think, are increasing in regularity in clinic. And I think that, the key thing is that we really want to prevent irreversible organ damage. So that the aim of treating a condition that is asymptomatic, if you can, is can I treat so this patient doesn't develop a number of fractures in their spine, or something that then they have to live with for the rest of their life, right? And with modern imaging techniques, monitoring of bloods, communication, hopefully, that is open and clear with patients, can we be in a situation where actually we can prevent that morbidity and that illness and those effects on organs that are basically irreversible? And that's the hope, right?
That is definitely the hope. Like I said, I'm sure the dial will shift on that.
Right, Sal. So it's probably time to wrap up our discussion about smouldering myeloma. Let's just summarize. So smouldering myeloma is an asymptomatic condition where people have between 10 and 59% plasma cells, myeloma cells in their bone marrow, with no evidence of damage to their organs, and they don't meet the criteria for SLIM, where we think there's potentially imminent damage going to happen to their kidneys or bones.
Not everybody with smouldering myeloma progresses. Not everybody needs treatment. And so we risk stratify those people as to their likelihood of progressing, and then follow up those certainly who are going to be higher, or higher risk of progressing, with blood tests in clinic and with scans certainly for the first 5 years to confirm that everything is okay and we can continue to monitor them.
We think, broadly speaking, maybe 50% of people progress within the first 5 years. Historically, that's the number that has been shown. It's about sort of 10% per year for the first 5 years. But then your chance of progressing does drop off to about 3% per year for the next 5 years. And then the rate of progressing after that is actually very low.
And then something else that's important to say, currently in the UK, we don't offer treatment for smouldering myeloma across the board. That conversation is ongoing and that may change, but at the moment the only way to access treatment for smouldering myeloma would be in a clinical trial. I'm aware that some may be coming through in the future, but currently there are none that I'm aware of that are recruiting in the UK.
Right, now Sal, and if you had to change the name of smouldering myeloma Do we think that smouldering is an appropriate term? I'm going to asymptomatic. Some people call it asymptomatic, but smouldering is the commonest terminology.
Smouldering is, and I find it really difficult. It's like you're grumbling along, isn't it? Or sort of slowly burning in the background. So what should we say instead? Should we try and coin a new phrase, Jam? Let me have a think.
I think we should, and I think if our listeners have got any ideas, let us know through social media, or let us know through our email, themyelomaminutes@gmail.com. But I think that's us on smouldering myeloma. So we're going to do a whole podcast on the treatment of smouldering myeloma and recent clinical trials, because that's a whole interesting podcast in itself. So look out for that one. But thanks for joining us today. Great to see you, Sally.
Keep in touch, everybody. Any questions, let us know. And speak to you and see you all again soon.
Bye. This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.